Good morning. It's Monday, February 23rd, 2026. In recognition of International Long COVID Awareness Month in March 2026, our discussion today will be on the topic of long COVID, past, present, and future, with one of the most renowned long COVID researchers in the world, Dr. Ziyad Al-Aly. I'm Dr. Susan Coe, a family physician working in Richmond, BC for the last 33 years. I'm a clinical associate professor at UBC and a member of both the Canadian COVID Society and Protect Our Province, BC. The Canadian COVID Society is a national nonprofit organization that works to inform the public about health consequences of COVID infections, to advocate for science-based measures to reduce the transmission of the virus, and empower and support people with long COVID. Protect Our Province of BC is a nonprofit grassroots organization consisting of doctors, nurses, health scientists, and community advocates striving to keep the people of British Columbia safe by sharing accurate scientific information about COVID-19. We begin by respectfully acknowledging that we are recording from the traditional, ancestral, and unceded territory of the Coast Salish peoples, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. And Dr. Al-Aly joins us from Washington University in St. Louis, which occupies the ancestral, traditional, and contemporary lands of the Osage Nation, the Oto, Missouri, Illinois Confederacy, Quapaw, Ho-Chunk, Miami, and many other tribes as custodians of the land where we reside, occupy, and call home. We are very honored to have joining us today Dr. Ziyad Al-Aly. Dr. Al-Aly is a clinical epidemiologist with the Washington University in St. Louis, the director of the Clinical Epidemiology Center, and chief of the research and development of the Veteran Affairs St. Louis healthcare system. Dr. Al-Aly led work which provided the first systematic characterization of the after effects of a COVID-19 infection. He then led work characterizing the increased risk of cardiovascular disease, neurological disorders, mental health disorders, gastrointestinal disorders, diabetes, dyslipidemia, and kidney disease following COVID infections. His lab also produced evidence characterizing the effects of COVID-19 vaccines on long COVID and the health consequences of repeated COVID infections. In 2024, Dr. Al-Aly testified before the U.S. Senate Health, Education, Labor, and Pensions Committee as an expert witness on long COVID. He called for the establishment of an NIH Institute to address long COVID and infection-associated chronic conditions and illnesses, also called post-acute infection syndrome. He was named one of the 100 most influential people in health in 2024 by Time 100 Health. Dr. Al-Aly, thank you so much for joining us today for this interview.
We're delighted to be with you, and thank you for having me.
As we enter the 7th year since the beginning of the COVID-19 pandemic, I would like to take a moment to remember the many lives lost to COVID-19. The World Health Organization estimates that over 7.1 million people have died from COVID-19 since it arrived in December of 2019. Unfortunately, the pandemic is not over, with new cases and new deaths still ongoing, and increasing cases of people who have never fully recovered from their COVID-19 infections and now have long COVID. Our discussion today will explore the past, present, and future of long COVID. I'd like to start the interview by looking back at where long COVID began. At the beginning of COVID-19 pandemic, there's a pervasive idea held by many health authorities that COVID-19 was a short-term acute illness. The term long COVID or long hauler was coined in the spring of 2020 by people suffering from persistent symptoms after COVID-19 infection. The term was first used by Amy Watson when she created the Facebook group Long Haul COVID Fighters in April 2020. Dr. Eliza Perigo was the first to champion the patient-made term of long COVID as a contracted form of a long COVID illness. Dr. Al-Aly, what is the current definition of long COVID?
So as we understand it today, long COVID encompasses all the long-term health effects of SARS-CoV-2 infection, meaning when people get SARS-CoV-2 infection and if they're experiencing problems, be it brain fog or fatigue, and if that lasts for long after the acute infection, and by some definition 30 days or some definition 60 or 90 days, but that's lasts longer than the acute phase, that is long COVID. And really, it encompasses, again, most importantly, all the long-term health effects of SARS-CoV-2 infection. It's not only limited to respiratory disease or fatigue or brain fog. It's all the long-term consequences of the infection. That's what we call long COVID today.
Dr. Ali, when did you first realize that some people with COVID infections were not recovering from their acute illness and had developed a longer-term illness?
So early in the pandemic, the cases here started growing really, really quickly in March of 2020. And then, shortly thereafter, we started sort of hearing from patients that, oh, I got COVID 2 weeks ago or 3 weeks ago, and then weeks later, I'm still having these problems. And these people were young. These patients were young, were healthy, previously healthy, did not have any medical problems at all. And so we started sort of thinking, like, what are these people talking about? They're young and healthy. And now at that time, we were told that if you're young and healthy, you get SARS-CoV-2 infection, you'll bounce back, and and there will be no long-term health effects. So we started thinking about what these patients are reporting, and started connecting the dots, listening to patient groups, the groups that you mentioned online and in the patients here in the clinic, and try to sort of connect the dots. And we started realizing that we've been told at the time that SARS-CoV-2 maybe is inconsequential in young individuals who are previously healthy and does not leave them with long-term problems. That's probably not correct. And these people are actually suffering and still having problems weeks after the initial infection.
Really interesting. Dr. Ali, you and your colleagues published one of the first studies on long COVID in 2022, the acute and post-acute sequelae associated with SARS-CoV-2 infection. Could you tell us some of the main takeaways from this landmark study?
Sure. So that was our first paper sort of cataloging what long COVID is. And what we did is that we took about at the time, 70,000 people who had an infection with SARS-CoV-2, compared them to 3 million controls at the time who did not have any SARS-CoV-2 infection. And we followed them for 6 months. And what we found that the people who had SARS-CoV-2 infection at the time, were coming back to the clinics with all sorts of problems. It wasn't only brain fog or fatigue or post-exertional malaise or what we associate today with as cardinal manifestations of long COVID, where it was really problems in the heart, some in the GI tract, some the neurologic problems. It literally, there was not a single organ system that we looked at that we didn't see any potential damage or any damage that is related to SARS-CoV-2 infection or long-term damage related to SARS-CoV-2 infection. So the key message from that paper was that yes, indeed, patients were right that there are definitely long-term complications or long-term health effects of SARS-CoV-2 infection, and it was not restricted to the pulmonary tree or the lungs or any single organ system. It was really evident across many organ systems in the body. So those are the two key conclusions there, that yes, indeed, long COVID actually exists and it's true. There are long-term consequences even in young and healthy individuals. And two, is not really confined to one organ system. It's not only a pulmonary disease or a cardiovascular disease. It was evident in multiple organ systems.
Thank you for sharing that with us. In this study and many of your consequent studies, you utilize a database from the Veteran Affairs St. Louis Healthcare System. Could you tell us the significance of this data bank for long COVID research?
Sure. So it's really one of the biggest healthcare databases in the United States and maybe even in the world. The VA system is sort of is unique in that it enrolls millions of veterans, and they get care within this integrated healthcare system. Even if they move from one city to another, they actually still get care within the VA system. The VA systems, all of it is computerized and integrated. So lab data is integrated with medication data, with hospitalization data, with outpatient data, which makes it really a wonderful resource in an emergent situation or an urgent public health situation like the pandemic, to really ask questions and address them in near real time. I think what made our group really sort of at the forefront of studying COVID and long COVID is that we were able to address questions in near real time. People would ask, "Oh, what about reinfection?" And we can go back to the data and do that work or the research to try to understand the effects of reinfection in near real time. What about the effect on the heart, the effect on the kidneys, the effect on diabetes? So we could do all of that in near real time, and that's really the beauty of VA data. I think one the lesson here to for governments and health systems worldwide is that these systems could come in handy exactly in times of emergency to help you address questions of public health importance. And we should continue to invest in improving these systems and even updating them to leveraging advances in AI and other technologies to really, because to help us address these key questions in public health.
Oh, that's a really important point. Thanks very much for sharing that with us. You also say the same group of people at year 2 and 3, the post-acute sequelae of COVID-19. What were some of the key takeaways from these studies?
Sure. So we weren't satisfied only to look at people only for 6 months or a year. We wanted actually to also look at what happens to long COVID 2 years or 3 years down the road. What we found, unfortunately, is that many of the people who really had actually been infected initially and suffered from a post-acute sequela or problems in the first year after infection, continued to have problems in the second year and even the third year after infection. And I think that's really, really important because a lot of people sort of think that, oh, well, you get long COVID and you get also over it, and it's a sort of a and over time it becomes milder, and that's really not borne out in the data. When we looked at the data, it was very, very evident that in people who've been infected, whether they were hospitalized for the infection, meaning having severe disease that necessitated hospitalization, or they had mild disease that they could nurse at home or deal with it at home. In both instances, there were, that single infection led to emerging sequela in the second year and the third year. And I told, I tell people here that, and patients that you may have actually forgotten that you got SARS-CoV-2 a year or two ago or 3 years ago, but it may not have forgotten about you. It's still potentially wreaking havoc in your system and producing disease and chronic disease.
This year's International Long COVID Awareness Month is highlighting the cardiovascular effects of COVID-19 infections. Based upon your research, could you tell us what these cardiovascular effects are?
Sure, and this is really very important because one of the key organs that COVID and long COVID affects is really the heart, and it can take multiple different forms. And some individuals can take simply the form of a bradycardia, or low heart rate, or fast heart rate in some individuals. Some individual may experience something we call POTS, or postural orthostatic tachycardia syndrome. One of the cardinal manifestations of postural orthostatic tachycardia syndrome is tachycardia. That is fast heart rate. Guess what that is? Like, that's heart rate, right? So it may be the genesis of that disease could be actually dysregulated autoimmune nervous system or autonomic nervous system, but it also hits the heart. In some cases, we also see people having minor or heart attacks. And in very, very severe cases, people can also get heart failure as a result of COVID and long COVID. And then the whole idea of clotting that has been described in multiple different organ systems can also happen in the heart. So the cardiovascular manifestation of COVID-19 and long COVID are, again, not only one thing. It can target multiple different areas of the heart, including clotting, abnormal heart rhythm, myocardial infarction, or what we call heart attacks, or even heart failure.
Do people who have mild COVID infections have the same cardiovascular disease risk compared to people who had severe infections that required hospitalizations?
Not the same, but not null. So it's very clear in the data that people who really have severe COVID-19 that necessitated hospitalization have the highest risk. That means that the risk is lower in people who had mild disease, but it's not null. It's actually lowest or non-existent in people who managed to protect themselves and not get SARS-CoV-2 infection in the first place.
Thanks for sharing that with us. Dr. Ali, in August 2023, you were interviewed by CNN about a study that found that long COVID creates a higher burden of disability than either heart disease or cancer. You said you were shocked by the study. Could you explain why?
Sure. So we did something called disability adjusted life years. So it's a health metrics that measures the burden of disability and disease that comes from, these cases of long COVID. Well, we measured it when we actually said, okay, well, let's sit down, actually look at the data and then measure this metric, like literally with a, measure the disability adjusted life years. And so we got numbers that actually rival the numbers that you get when people have cancer and heart disease, meaning that, people trivialize long COVID. It's like, oh, it's just brain fog or just fatigue and you're just tired and you go walk it off or, exercise and it'll go away. That they're missing the point. When we actually objectively measure the burden of disability and disease in people with long COVID, we get numbers that are on par or actually eclipse numbers that people get when they measure the burden of disability and disease of people who have cancer or heart disease. And that's really very, very important in health metrics because, we would want to be able with numbers to communicate to the world, like how does this disease compare to other diseases that are well known? People connect viscerally to stories about cancer and heart disease because it's very, very well known. So we did the work to try to evaluate the numbers, and it's very, very obvious, very, very clear. The disability adjusted life year from long COVID rivals or even eclipses the numbers that you get from the DALY or the disability adjusted life years numbers that you get with either cancer or heart disease.
Now, that's really, truly alarming. At the beginning of the pandemic, it was initially thought that having infection with COVID could protect a person from future infections. But in November 2022, you published an important study about the acute and post-acute sequelae of SARS-CoV-2 reinfection. Could you tell us about the key points from this study?
Sure. I mean, at the time when we started getting people telling us that, oh, I've had COVID before and, I also had been vaccinated. So they had this air of invincibility about them that they were, walking around, invincible, that they had been vaccinated, had COVID-19 and had built up this immunity. And the term hybrid immunity was sort of circulating everywhere. So people sort of became all of a sudden immunologists and they started learning oh yeah, I have a hybrid immunity because I have immunity that is derived from vaccination and also immunity derived from natural infection. So I have this double immunity and robust immunity and I'm feeling invincible. And then and then I shouldn't really do anything about protecting myself from COVID because I'm invincible. I'm a Superman or a Superwoman and then COVID is not going to affect me. So asking the question, are these people right? Are they right? Is this really true? Are they truly invincible? So we studied reinfection, and it was obvious in the data that reinfection is can put people at risk of having having long COVID again. And then if you dodge the bullet once, meaning that if you had the first infection and dodged the bullet and did not have long COVID, it does not really mean that you're going to dodge the bullet again. You can still have long COVID on a second infection or a third infection or fourth infection. So reinfection is not inconsequential. Reinfection contributes additional risk of severe COVID-19 and also long COVID.
It's a really important point. Yeah, thanks for bringing that up. I really appreciate you telling us about that. It has been said the best way to prevent long COVID is not to get COVID infection in the first place. In August 2024, you published an article with notable long COVID researchers, including Dr. Eric Topol, Dr. Hannah Davis, and Dr. Akiko Iwasaki, to review the evidence that vaccination did provide protection against long COVID. But in September 2024, the Mayo Clinic released a study that found vaccination did not significantly reduce the risk of long COVID. Could you explain these contradicting results?
Yeah, we don't see them as contradicting. I mean, the body of evidence, you always want to look at not one paper, not two papers, but the whole body of evidence, collectively from multiple different streams. So when we evaluated the evidence landscape, looking at more than 25 different studies from various countries, from the US, from the EU, including Spain, including the UK, and several other places in Europe. There is a near universal consensus that vaccines do reduce the risk of long COVID. So this is really very, very, very obvious in the data. Now, sometimes people may do a study that differs methodologically and they may, sort of miss some confounding and then come up with different conclusions. I don't want to sort of specifically interrogate that. But I think when we, as a scientist, when sort of evaluating the body of evidence, always we want to evaluate the totality of evidence coming from most of these studies, literally, from multiple different angles and different settings, different methodologies, different countries. and some enormously large ones have universally come to the consensus that vaccines do reduce the risk of long COVID.
That's really good to know. Thank you very much. I would now like to discuss the present state of the COVID-19 pandemic and long COVID. A systematic review in September 2025 found 36% of people globally have long COVID, and this rises to 40% among healthcare workers. It is estimated that more than 3.5 million Canadians and 65 million Americans have long COVID, and yet so many people, including our own medical colleagues, many healthcare professionals, and the general public have very little knowledge about long COVID. At the U.S. Senate long COVID congressional hearings in 2024, you said that long COVID can affect any age, from a child to a person who is 100 years old. Which groups of people currently have the highest rates of long COVID?
Sure. So long COVID can affect people across the lifespan. And we have kids who are suffering from long COVID, and we have people who are, as you indicated, people who are literally in their 80s and 90s and 100 years of age who actually have long COVID. So it can affect people across the lifespan and can affect people across different demographics groups. Now, having said that, the prototypical type of long COVID, the type of long COVID is characterized by fatigue, post-exertional malaise, brain fog. In some cases it could be POTS. That tends to be, that tends to happen more in women than in men, and then the age distribution tends to happen, generally speaking, in younger women, in people in their 20s and 30s and 40s. That's a generalization, and obviously, and we have tons of people with long COVID who are men, and tons of people who are with long COVID who are older adults and in pediatric age group, right? So, but generally the distribution is that tilts more toward women than men for the prototypical type of long COVID. I think what makes long COVID, complicated is that it's really not one thing. I mean, as we just, discussed, long COVID can affect the heart, can affect the metabolic system, can affect various organ systems, and the prototypical type characterized by fatigue, brain fog, POTS, and post-exertional malaise, that generally is more in women than in men.
At the beginning of the pandemic, there's a belief that children did not get as sick as adults after COVID infection, but this has been proven wrong, with some children developing severe multi-system inflammatory syndrome, and some children now going on to develop long COVID. How common is long COVID in children?
So unfortunately, there's not a lot of, it's not as clear as adults. Some studies put it about 6%, and there are various numbers out there, some lower and some much higher than that. What is really clear to me is that this is also a problem in kids. This is really actually happening in kids. Definitely, long COVID can happen in kids, and while the epidemiology might be slightly different than long COVID in the adult population, it is also a significant problem in kids for sure.
Thank you for sharing that. The Canadian Pediatric Society released a position statement in November 2025, which classified many symptoms of long COVID under the umbrella of somatic disorders. Many neurologists in Canada believe that long COVID is a functional neurological disorder. Could you describe the difference between somatic and functional neurological disorders, and why these terms are being used for long COVID?
I think there's a different sort of school of thought and different sort of ways of looking at long COVID. When we see it in the data and see it in patients, it's really clearly objectively there. Again, it's not only fatigue or brain fog. People are having heart attacks and people are having metabolic problems that are measurable, and so we the way we define long COVID and that's really also the consensus definition by the National Academy of Medicine in the United States, the highest academic body in the US, there's a universal consensus that long COVID encompasses all the long-term health effects. And then among these, there's kidney disease, there is diabetes, there is all of these objectively these are objective parameters and objective disease states that can be measured. So it's again, I don't want to speak to how others really think about it, but it's very obvious to me that it is it is a disease state that emanates or originates with SARS-CoV-2 infection with multiple manifestations that are measurable, that is really, across many body systems.
What kind of work needs to be done for long COVID to be properly characterized within healthcare and beyond?
I think there is a lot. This is a lot needs to be done here. More recognition of what long COVID is, more research on long COVID to better understand the epidemiology, to better understand several of the questions that you ask, and it's like, okay, like we don't really have a full answer here. Long COVID in kids, et cetera, et cetera, and really most importantly, a better understanding of the mechanisms, like why long COVID really happens in individuals and how to best treat it. So there needs to be a comprehensive research strategy that targets multiple different prongs, not only understanding long COVID, not only, doing more mechanistic studies, but also treating it, translating that treatment into actual practice and educating the community of providers, throughout the world, and how to better address the healthcare needs of people who are suffering from long COVID.
Totally agree. Thanks for sharing that. People with long COVID can present with any number of over 200 symptoms, but what are some of the most common symptoms of long COVID?
This is really a beautiful question. And the 200 symptoms come from like really the early wonderful report from the patient-led research collaborative report of, cataloging the breadth of organ dysfunction and the breadth of manifestations of long COVID. And when you total them, it's about 200 symptoms in various organ systems. However, having said there are 200 different things, the most common thing that are really, are evident in clinics and clinical practice when you see and talk to people with long COVID is, fatigue is a big one, is one of the cardinal manifestations of long COVID. Post-exertional malaise, and that distinguishes from fatigue is it's not really just being tired, is it's really, profound malaise, profound exhaustion after even a mild exertion. And that could be walking the dog for half a block or a block or two. It could be doing the dishes or doing something simple around the house that leaves people with a profound exhaustion. Sometimes it takes them hours or even days to recover from. We call that post-exertional malaise. It's a very, very important state or disease state that people need to understand. The third is POTS, or postural orthostatic tachycardia syndrome. This also seems to be common in some individuals. And then it would be remiss without mentioning here one of the cardinal manifestations, brain fog or cognitive dysfunction. That's really also can take form of a mild cognitive dysfunction where people sort of forget things here and there to really more debilitating and more severe form of cognitive dysfunction. So all of those can happen in individuals, can happen in all of them in the same individual, or some people can have only PEM or post-exertional malaise, but not the others. And again, along with the other, manifestations of long COVID.
Thank you very much for sharing that. As a clinician, when I tell some of my patients their symptoms are consistent with long COVID, many of them tell me that this is not possible because they don't think they've ever had a COVID infection. How can people who have never tested positive for COVID still be given a diagnosis of long COVID?
Well, it's really the probability of somebody having had no exposure to COVID is low. It's not zero. Obviously there are some people who really protected themselves, but if people are living in the community and interacting with other people and have lived with that for the past several years, the probability of somebody having totally avoided COVID and is totally immunologically naive and have never experienced COVID before is low. Is very, very low. It's not zero, but it's very, very low. Seroprevalence estimates when we, it suggests that most people around the world have had COVID at least once. Most people. And that's a generalization, but that's like most people. Again, that doesn't really mean that some people could not protect themselves. Some people are truly immunologically naive and have never had a COVID infection before. So that can happen, but it's very, very rare. And then so long COVID can definitely happen even in people who had an infection but they didn't really realize they had an infection. They may have an infection that was silent, that didn't really produce any major symptoms, or they may have felt sort of under the weather for a few hours and their body got over it, and it's like, oh, they didn't test it, they didn't know they had a SARS-CoV-2 infection, and then 2 weeks later it's like, oh, why can't I start having brain fog, like why can't I remember this or remember that, and then they were diagnosed with brain fog. It's like, okay, well, those are likely related to an infection that you likely had, but didn't realize you had because you did not get tested, you did not, et cetera, et cetera. So that's actually unfortunately not an uncommon scenario, especially when testing rates have declined dramatically and people are not are foregoing testing. So people show up to clinics like, oh, I'm having this problem, and then you track it back. It's like, oh yeah, like 3 weeks ago or 4 weeks ago or 2 months ago, I felt under the weather for a couple days and had sort of symptoms like that, like a cough, but I didn't test, and that was most likely had COVID, but they didn't know they actually had COVID, and I end up in the clinic two months later with problems related to that infection without knowing that I actually had it.
Thanks for explaining that to us. There are some recent studies looking at MRI brain scans that showed interesting things in people who have long COVID compared to people who'd never had COVID or people who've been fully recovered from COVID. Could you tell us about this?
Sure. So there's actually quite a bit of studies that have been done over the past several years to try to help us understand what happens in the brains of people with COVID, and it's very obvious that COVID there is what we call neurotropism. What that really means, it means that the SARS-CoV-2 virus can actually find its way to the brain in some individuals, not in everybody, and it can actually lead to inflammation in the brain, activation of these small immune cells called glial cells in the brain, can lead to disruption of the blood-brain barrier. That's sort of the barrier that actually is kind of like the shield that is around our brain that's supposed to protect our brains from things. COVID-19 or SARS-CoV-2, the virus that causes COVID-19, can actually disrupt that blood-brain barrier. And then there have been studies, as you pointed out, MRI studies and others that shown structural differences or structural changes in a reduction in some, in the size of several brain regions after people had SARS-CoV-2 infection. So when you put all of this evidence together, it's very obvious that SARS-CoV-2 it's a misnomer when people sort of I think a mischaracterization when it's sort of characterized as solely a respiratory virus. It's not a solely respiratory virus. It's very, very obvious it can actually lead to problems in the brain. Again, brain fog is one of the cardinal manifestations of long COVID. In addition to this, have been, literally a wave, more than 100 study, cataloging what happens in the nervous system, including the MRI study that you just cited, and many others. So we're not resting the evidence here on a single study or a single observation. There's a body of evidence, showing that SARS-CoV-2 is neurotropic, meaning it actually can find its way to the brain, can disrupt the blood-brain barrier, and precipitate or result in inflammation in brain tissue and activation of immune cells inside the brain that's grossly abnormal, that should not really happen in normal situations, and leading to structural changes. And the clinical phenotype that we see obviously people with brain fog, but not only that, in severe cases, you can see people with seizure disorders, people with strokes, and multiple other problems, in addition to brain fog. So people focus a lot on brain fog, but it's not really the only neurologic dysfunction that can happen in the setting of severe SARS-CoV-2. Obviously, people can have seizures, stroke, and in very rare cases also, global inflammation of the brain or encephalitis.
That's really interesting. Thanks for sharing that with us. At the beginning of the pandemic, COVID was thought to be a respiratory disease, and you alluded to this just now. The British Medical Journal just published an article in February 2026 called Why COVID-19 is a Vascular Disease Masquerading as a Respiratory One. What do you think about this assessment?
Well, we totally agree. And actually, we are one of the groups here that very early on in the pandemic sort of called attention to this. And I remember doing a lot of interviews and telling people that the R in SARS-CoV-2 stands for respiratory, but it really is wrong, because SARS-CoV-2 is not only a respiratory virus, it attacks many body systems, and we see cardiovascular manifestations. We just talked about neurologic manifestations. So it's really more, it's not even a cardiovascular, I mean, I agree that it definitely cardiovascular, but not only. I would classify it as a systemic infection, because it's really can affect multiple organ systems. And some individuals, certainly cardiovascular, but some others neurologic, and some in other people maybe metabolic, and in some people all of the above. So the R in SARS-CoV-2 that's supposed to denote or represent respiratory is really not a full characterization of the extent of damage that SARS-CoV-2
Mhm.
can wreak in the body, including cardiovascular system and neurologic system.
Those are really important points. Studies have also shown that mild or moderate co-infections, there can be persistent immune damage lasting for months, particularly in long COVID patients. If we consider permanent immune effects from COVID alongside declining vaccination coverage and the reemergence of diseases like measles, what are the potential implications of this at a population level?
This is really a brilliant question. So thank you for that. And I think it's really important to understand it now, because we've been, we've had now COVID for several years, and there is this idea, the school of thought, that COVID-19, actually changes the immune system in a way that makes people more susceptible to actually having infection with other pathogens. We've done a research on this actually about a year and a half ago, and then we published in the Lancet Infectious Diseases, showing that people who had actually SARS-CoV-2 infection compared to people who tested negative for SARS-CoV-2 infection had a higher risk of developing infections, future infections with other pathogens. And I think this is really one of the explanations why this flu season is really particularly worse than prior seasons, is, as you noted, the vaccine uptake is lower than prior seasons. But it's also possible that us as a population being infected multiple times over the past several years with SARS-CoV-2 sort of led to some form of immune damage or immune system disturbances that made us actually more susceptible and to actually encountering the flu infection. I think that's really a hypothesis that needs to be further evaluated, further tested. But I think it is plausible as a hypothesis. I don't want to sort of as a scientist sort of present it as a foregone conclusion or as a scientific fact, but as a hypothesis, it actually deserves to be tested. Very, very important.
Yeah, I totally agree. In my community, we're seeing people that are being admitted to ICU with severe pneumonias caused by adenovirus, which is basically the common cold virus. This is not something we used to see commonly before the pandemic, right? So
No,
thanks very much for sharing this.
that's exactly the point that we when we looked at the data systematically, and think we saw that the people, compared to the people who tested negative, people who tested positive were coming back with all these weird infections down the road, like even with multiple different pathogens. So it's very obvious that there may be a relationship between, like, that an infection with SARS-CoV-2 sort of changes the immune system in a way that makes it more susceptible to encountering future infections. That doesn't only apply to the flu, but applies to other pathogens as well.
Thank you very much. Insurance companies are reporting that the rates of cancer have increased significantly since the COVID pandemic. Much has been attributed to delays in diagnosis and treatment, but there are emerging studies that have found that COVID infections may lead directly to cancer. Do you think the worldwide increased rates of cancer have a direct linkage to COVID infections?
I don't think the science on this is settled yet. I think that we are, cancer takes a long time to happen. Like cancer does not really happen overnight. And this pandemic or the COVID-19 pandemic is relatively young, so to speak. It's not like, it's not even 10 years, or it's not even a decade old. So, So I don't think that the verdict is out on this, but it worries us enough to really actually to have now here devoted. We are going to study it, and there is a pipeline of research now that's being stood up or being put together to really evaluate this hypothesis. But we don't expect like that the you know cancer epidemiology would dramatically change in a very short period of time as a result of SARS-CoV-2 infection. But like most things with epidemiology, it's likely also multifactorial. It's likely that there's a contribution for various other factors, environmental exposure, other behavioral factors, economic conditions, that may have contributed to the changes in cancer rates in the US and elsewhere in the world as well.
Thanks for telling us about this. Now, preventive medications and treatments for long COVID are not fully established, but there are a number of emerging options. In March 2023, you and your colleagues published a study which found that the antiviral medication nirmatrelvir-ritonavir, also known as Paxlovid, reduces the risk of developing long COVID by 26%. But other research, such as the January 2024 USC study, found Paxlovid did not reduce the risk. So does Paxlovid reduce the risk of long COVID?
So Paxlovid, when taken in the acute phase, when taken around the acute infection, I think there's also now evidence not only from our center, but also from multiple other centers and multiple other places in the world that suggesting that Paxlovid reduces in the acute phase reduces the risk of long COVID. That's really seems to be clear. There is a randomized control trial that has been done in Norway, the results of which are going to be hopefully published very soon, suggesting also the same thing. So there's a convergence of evidence, if you will, that Paxlovid, when taken in the acute phase, again, has to be in the acute phase, reduces the risk of long COVID.
Really good to know. Thanks for sharing that. Could you comment on studies, including a recent one published in November 2025, that found that the common diabetic drug metformin may also reduce the risk of long COVID by as much as 53%?
Yeah, this is very, very interesting. So we're very intrigued, and I'm really familiar with the research group that put this out and their wonderful contributions, and grateful for all of that. I think it's plausible that metformin might affect inflammation. Some people suggest that it may have a weak antiviral activity or modulate the immune system in some way. Metformin is an old drug that has been around for a long time. It is cheap. It is safe. So I think this is welcome news, and I think I'm actually surprised that why not more people do this or take metformin, because again, it's relatively cheap. It's not relatively cheap, it's actually very, very cheap. It is safe. It's been around for a long time. Now, do we fully understand why with metformin, initially developed for diabetes and actually early stages of diabetes, not advanced stages of diabetes, and would actually work on long COVID? I don't think we fully understand that. Again, sort of a hypotheses out there regarding anti-inflammatory activity, antiviral activity, and some modulation of the immune system. So those are sort of a hypotheses. There's not a whole lot of mechanistic work there to try to help us understand why does it work, but it seems to be a compelling story with low risk. So I think that's very, very, very interesting data.
Yeah, I totally agree. I think more people should know about metformin, especially since Paxlovid is such an expensive drug in comparison, right?
With side effects, right? So Paxlovid
Yes.
obviously is an antiviral, has side effects and enormous expense. But also, I would like to say that they're not mutually exclusive. Like if they're like the idea that people could do both Paxlovid and metformin to further suppress the rate or reduce the rate of long COVID.
Thanks for sharing that. Many people are seeking to protect themselves from long COVID. What would you recommend people do?
I think the best idea is to try to reduce your risk of getting COVID in the first place. For those people who are really, for example, work in high risk settings, fly a lot, take public transportation, find themselves in areas where there is crowded areas where there's a high number of people or sick individuals, et cetera, protecting yourself, trying to reduce your own risk of developing long COVID. And that can take multiple different forms. Avoiding high risk areas in the first place, like if you don't really need to be in that crowded hall with a million other people who are coughing and potentially have disease, try to reduce your risk. If you're going to a restaurant and then you have the choice of sitting outside versus sitting inside, well, sitting outside is a lower risk than sitting inside. Masking on airplanes, masking on in high risk settings, et cetera, and really very, very important, trying to improve indoor air quality. That's really, really very, very important because SARS-CoV-2, as opposed to a lot of other viruses, is actually airborne. And one of the things that you can actually try to do to reduce the burden of airborne disease like SARS-CoV-2 is really improve indoor air ventilation, and that can be done relatively cheaply with existing technology. It does not need to be fancy new installation or fancy new technology. With existing air purifiers, you can sort of increase exchanges. Or with existing technology, is relatively cheap, relatively affordable to try to improve indoor air quality and reduce the burden of infection. Now, that does not really eliminate it. It's not going to make it zero. People can still get infected, but it reduces significantly. And the other thing that's really very important is liberal sick leave policies. It continues to amaze me how people are sick and coughing and sneezing, and then they brave it and they show up to work, and both employees
Mhm.
and employers accept it. That should not be acceptable. That should be that if you're sick, for your own sake and for the sake of your colleagues, the other employees, and and that's a really generally a function of culture, a function of and work policies or sick leave policies. So having sort of reasonable sick leave policies is going to encourage people to stay at home when they're really sick. So again, to review this, because I think it's a long-winded answer, Susan, to review this, it has to be a multi-pronged approach. It cannot be one thing. It cannot be only like, oh, well, I'll improve indoor air quality and then be done with it. If you really are serious about protecting yourself from COVID-19 and other respiratory diseases, not only the COVID-19, it's like other respiratory diseases that you can also protect yourself from. Having a multi-pronged approach, a multi-layer approach, hitting all these different things is really effective. Again, it's not going to reduce. None of this is going to reduce it to zero. To reduce to zero, you have to do really, a lot of things. But these measures are, reduce the risk significantly. I think significant enough to justify the minimal cost again, and that is that one has to pay to support these prongs.
I could not agree with you more. Thanks for those answers. You mentioned already that vaccination reduces the risk of long COVID. Based on current evidence, is there any one COVID vaccine superior to another? For instance, Novavax versus the mRNA vaccines.
This is really a beautiful question, and I think we get that a lot because a lot of people sort of like there's some aversion to mRNA vaccine, and there's like the truth is, in the United States, is that most vaccines now for COVID, like at least in our system, more than 99%, Susan, are mRNA vaccines, and so it's really, and there are no, I mean, you ask, and as a scientist, I have to go by the evidence. There is really no compelling evidence that one vaccine technology is better than the other vaccine technology. What we really know for sure, though, is that vaccination is better than no vaccinations. Vaccination does not eliminate the risk of long COVID, but it reduces the risk of long COVID. And I think that really is reduces the risk of severe COVID in the first place, reduces the risk of hospitalization, reduces the risk of death, and reduces the risk of long COVID.
Agree. The issue, as you mentioned, though, is that there's people that have had adverse reactions to the mRNA vaccine. So it's important, I think, to have Novavax as an option. And
we cannot agree more. We agree wholeheartedly. It is the
yes,
that definitely definitely our feeling too. Is that the fact though in the United States is that it's not even there's not enough. It's not even something that we can even study because it's not available in our system.
I agree. A number of studies have also found that intravenous immunoglobulins are effective in treating long COVID, including long COVID in children. Could you tell us more about this treatment?
Sure. So there is this idea long COVID can be, mechanisms of long COVID can be, there are multiple different mechanisms. One of them is dysregulated immune response, and one of the ways to sort of to treat that is to give the body IVIG, those immunoglobulins that sort of modulate the immune response. There is some data in animals that IVIG might work. There is some anecdotal observation, small studies in humans suggesting that it actually might work. So there is when I say it's like small studies, like really one, like n equal 1 or n equal 2, like very small studies, very small observations here and there, suggesting that IVIG or intravenous immunoglobulin might work. So it's the good thing is that there is some evidence out there that's showing it works, but I think we would like to see a more systematic studying of this in a randomized placebo-controlled trial where we actually evaluate IVIG versus a real placebo and then demonstrate that actually really reducing the risk of long COVID. The biology is maybe plausible, as we said, sort of one of the key mechanistic pathways for long COVID is dysregulated immune response. And then that may be quieted down or restored to health with IVIG. So there's some plausibility to that claim, but again, it has to be tested in randomized controlled trials for us to feel more confident that this is really actually working.
Thank you very much for telling us about this. In Canada, we are starting to have some clinics which treat long COVID patients. This includes the BC Long COVID MECFS and Epidemiology Clinic, the Cornerstone Physiotherapy Clinic in Toronto, and the UHN Long COVID Inpatient Program. What is the evidence behind multidisciplinary treatment centers or rehabilitation centers for long COVID?
I think we need to know more. We need to do more there. I think one of the ideas for multidisciplinary approach to long COVID is that long COVID itself is a multi-system disease. It's not only cardiovascular, it's not only neurologic. It's really a multi-system disease that requires a multi-system solution. And then if you sort of send the long COVID patients to the heart doctor, and then to the kidney doctor, and then to the neurologist, and then to the endocrine, or then to the that's sort of like really amazing having sort of a hub where a multi-specialty hub where people could provide, where providers could provide these services to patients who have multi-system disease might be the right model. With an emphasis on might, because as a scientist, I actually would like this to be evaluated. Like, is this like really a better model than, say, an experienced primary care physician who can actually provide very similar services and at a lower cost, and actually could solve the access problem because how many specialty clinics can you have? But you can have only a very small number of them, but you have a many more primary care physicians. So endowing primary care physicians with the ability and the knowledge to actually deal with patients with long COVID is really going to be key. And then potentially referring the complex cases that the primary care physician feels that they're too complicated, they're too involved for them to be able to manage them at the primary care, in the primary care clinic, then referring those to specialty centers. So I think all of that needs to be evaluated empirically to try to help us understand what's like the best model that's going to create the best outcomes for patients at a reasonable cost for society. And it's going to be also scalable to match the need, to match the so those considerations need to be happening in the field of long COVID to try to help us understand where we're at. Now, the reality in the United States, though, is like total opposite. There's closures of long COVID clinics. A lot of people sort of like moved on from the pandemic. A lot of health systems are overwhelmed with other priorities. So they're shifting resources from long COVID clinics to other areas, to cancer clinics, to diabetes clinic, Ozempic clinics, et cetera, et cetera. So they're shifting resources around. Health systems are shifting resources around that is taking away from long COVID. That's really the reality. The reality is not that there is more effort here to build multi-specialty clinics. There's actually erosion of existing clinical infrastructure over the past year or so. Actually, more than the past year, significant erosion conversion in a number of existing clinics to the point that several of them, many of them actually already closed. And then patients had to go back to their own physician who may or may not know about long COVID. So the key here is to try to make sure that professional societies and all of us are pushing forward to try to educate and train primary care physicians, because they are the first interface. They are the first layer where patients are not going to be going to the specialty clinics directly. They're going to go to the primary doctor and say, well, I felt under the weather like several weeks ago, and now I'm having this sort of a haziness in my brain, and I cannot remember things. And then that doctor needs to be endowed with the knowledge and the know-how to be able to connect those dots. Like, okay, you actually likely had a COVID infection. Now what this is really brain fog. And then and help walk them through the journey of dealing with that and addressing that. So that's going to be very, very important. Educating and training primary care providers to really address most of the healthcare needs of people with long COVID.
As a family doctor, I could not agree more. And also as a teacher of medical students, I could not agree more. And this is one of the things that we're trying to do at the Canadian COVID Society and Protect Our Province BC, is to educate our primary care physicians about long COVID. So thank you for bringing up this really important point. I would now like to discuss the future of long COVID. When you testified at the U.S. Senate congressional hearings on long COVID, you said that the U.S. had some of the best researchers in the world and should be able to find a cure for long COVID. What are some of the promising investigations on the horizon for long COVID?
I think there's a lot of exciting work that has been happening. I think that there are key insights over the past several years about like why long COVID is happening in terms of mechanisms, like some ideas about viral persistence and some work in there, ideas or work that has been done on, thromboinflammation or inflammation of the vessel wall and, microclots or clotting and complement activation, really exciting work, exciting papers in that regard. There's quite a bit of work that has been done also on evaluating the immune profiling or immune changes that happen as a result of COVID and long COVID, and identifying signatures there that could be used as levers or could be used as therapeutic opportunities to help devise new drugs, or even use existing drug or repurpose existing drugs to try to see if those could also help with long COVID. So there's quite a bit in the area of mechanisms to try that enhance our understanding over the past several years as to why long COVID happens and how is it happening, and sort of the mechanism of it. And there is some ongoing efforts by the NIH and many others to try to find treatment for long COVID. There's trials out there. Some of them in the initial phase, some of them are already enrolling, and to try to test different therapeutics, whether it's GLP-1 or various drugs to test the effectiveness or efficacy in reducing or ameliorating or improving long COVID. And there is quite a bit of work in sort of in the epidemiology sphere also to try to understand like the long-term effects of long COVID, the 5-year outcomes, and what happens after that, sort of putting infrastructure in place so we don't forget about the people who are impacted, and we track them and are able to understand what's happening to them 7 years down the road, 8 years down the road, and 10 years down the road.
Vaccines have significantly reduced mortality from COVID-19, but current vaccines do not give long-lasting immunity and do not fully prevent transmission of the disease. What are some promising research initiatives looking into a more effective vaccine?
Sure. So SARS-CoV-2 vaccines are I think they get a bad rap because people's expectations that they would take it once and they would that's all they need. The truth is that SARS-CoV-2 vaccines, for various reasons, one is really the longevity of the vaccine itself. It doesn't really last long, and two, because SARS-CoV-2 itself changes quite dramatically. It actually continues to mutate. There's always new strains and it's always evolving. So people will need to get vaccinated once a year with SARS-CoV-2, and that's really the current situation. Now, looking at the future, I think there are promising vaccine technologies that potentially could make the vaccine sort of more effective against a wider range of SARS-CoV-2 variants. Currently, the mRNA technology that is we currently use is that we sort of like, okay, well, is this like a vaccine target toward the KP or the XBB vaccine or the JN.1 vaccine? So it's really targeted toward a really a narrow sort of a spectrum of variants, if not like only just one predominant variant that we think maybe predominating or maybe dominating at the time the vaccine is actually ready to be distributed and the season is spiking. So that's really a bit sort of a there's a bit of a asynchrony there. I think going into the future, sort of trying to engineer a vaccine that would be pan-coronavirus, meaning that they don't like you don't have to design an XBB or a JN.1 or a KP vaccine, but it would be pan-coronavirus vaccine. Those could be potentially promising technologies that would hopefully result in longer longevity or longer durability of the vaccine. But that also remains to be tested. Currently, as it stands, people's expectation need to be matching with reality. The reality is that current vaccine technologies do not last long. And the virus continues to mutate so that what you got for XBB several years ago no longer works against the current virus because XBB is come and gone. It's actually come and gone. And now we have a totally different SARS-CoV-2 altogether. So people need to remember, like, although you may have gotten the COVID vaccine last year, you need to get it this year, and you're likely going to need to get it next year until such a time where we have a vaccine technologies that are span a broader array of SARS-CoV-2 variants or pan-coronavirus vaccine, that covers multiple variants at once and also have a longer longevity or longer durability.
That's very interesting. Thanks for sharing that. Are there any emerging antivirals that could reduce the risk of developing and or be used to treat long COVID?
So there are antivirals out there being developed, multiple antivirals are being developed. Sort of at this point, sort of it's not really clear if any of them will actually be as efficacious or less or more efficacious than the current antivirals that we have. The two key antivirals that we have currently are the molnupiravir and the Paxlovid. And Paxlovid being sort of the most commonly used. Your listeners might be asking, like, why would we need more antivirals? We need more antivirals because antiviral resistance is actually a real thing. And then you don't want to live in a world where we're relying or putting all our eggs in one basket or two baskets, the molnupiravir and the and Paxlovid. Should the virus develop in a way or become sort of that becomes immune or resistant to these existing platforms or existing antivirals, you need to have other things in your bag of tricks to be able to release to treat SARS-CoV-2. So reliance on a one thing or putting your eggs in one antiviral is never really a good thing because viruses are continuously evolving, and with enough pressure that comes from potentially a bunch of people taking antivirals, et cetera, could actually make the virus mutate in a way that it become resistant to Paxlovid or molnupiravir or even both. And then so those are really important concepts for people to understand. That's really why we need more antivirals. The second thing is that the really uptake of antivirals has been hampered by the fact that they actually have significant adverse events and also associated costs. To the extent that we could also solve these two problems, may help improve access to those who need it.
Those are really good points. What are some of the promising therapeutics and supplements which would be used to treat long COVID?
So currently, I have to caution the listeners here that or the audience here that there's currently no approved therapeutics for long COVID. There's no FDA approved medications. I have to be very, very candid and have that disclosure that they're currently in the US and in the EU and elsewhere, there is no regulatory agency that has approved any drug for long COVID. However, multiple drugs are being tried, in randomized controlled trials and clinics throughout the country, in the UK and EU and in Canada and elsewhere. People are trying things because people need help and people want help and people want to feel better. So there are various sort of modalities that have been are being tried. Some in formal randomized controlled trials and some in just clinical practice. People are using all sorts of things, including GLP-1, including metformin, including naloxone or naltrexone, multiple different things to try to help assuage or help address some of the problems in their patients. So there is a lot out there. Again, I want to caution that there isn't really no definitive evidence that supports one modality over the other. I feel that people or practitioners or providers and patients are trying to do their best to help their patients, but there need to be more trials to more systematically evaluate these therapeutic options to help us understand what works and what doesn't. Because none of these things, actually, also what I failed to mention is the anticoagulants. There's also a body of a number of patients who also and providers who also subscribe to the idea of anticoagulants so again, I mean, those may work or may not work, but we need trials to help us understand, because none of this is really without risks. Maybe with the exception of metformin has a very, very low risk profile, but medications generally have risks, and we want to understand the benefit and whether they actually really work or their benefit in clinical trials before endorsing one approach over another.
It's a really good point. Thanks for telling us about that. As a leading researcher in long COVID, what keeps you up at night?
I think the key thing that we've been noticing here over the past several years, or actually the past year, is really this shift from long COVID and COVID and also like this effort to sort of move on from the pandemic as if it didn't happen and not learning the lesson from the pandemic. I mean, the key thing that I really feel that is really that the sort of I feel is very important is that we already paid the price for this book. We already paid the price for this horror show that's called The Pandemic. Might as well learn from it. We already paid, you opened the piece by reflecting on the number of people who died from COVID-19. Millions of people died from COVID-19 in the world. So we already paid a heavy price, a very, very, very heavy price for this global pandemic. The least we could do is really learn from it, like the lesson that it offered us. It offered us the idea that, well, an infection with SARS-CoV-2 with an R in its name, with a respirator in its name, actually ends up leading to a multi-system disease called long COVID that affects 400 million people. So we need to take that lesson and understand that acute infections can actually lead to chronic disease. It's very, very obvious to me. One of the key lessons of the pandemic that acute infections can lead to chronic disease. This idea of thinking about acute infections as solely acute diseases or infections that lead to acute disease and ignoring what happens later on is really very, very similar to just looking at the tip of the iceberg. You're focused on what's immediately visible in front of you, and that's okay, but you need to also realize that beneath that tip of the iceberg lies a huge burden of disability and disease in the form of long COVID, and that's really one of the key lessons of the pandemic. And why do I worry about that? I worry about that because pandemics are going to happen. So this is not the first one, and it's not going to be the last one. So we are going to have another pandemic, whether in 2030 or 2035 or 2040 or 2050. We don't know when. We are going to have other pandemics in the future. And I worry that we might go into those pandemics also blindfolded and ignoring the lessons that we learned in this pandemic. And then again, like this is something that we already paid the price for. We already paid the price for this course. We already paid the price for this movie. We already paid the price for this book. Might as well learn from them because pandemics are going to happen and we're going to face this again. And it would be better, we would face it in a much, much better way if we are equipped with or armed with the lessons and the knowledge that this pandemic already offered us.
Those are really important points. Thanks very much for sharing that with us. MIT physics professor Dr. Yanir Baryam, in October 2025 interview, has called COVID an existential threat to human health because every COVID infection, whether it is mild or severe, increases the risk of heart attack, stroke, diabetes, dementia, immune system dysregulation, and reactivation of viruses such as Epstein-Barr. And each infection can also lead to long-term impacts to health, such as long COVID. The economic burden of long COVID has been estimated to be $1 trillion globally due to the direct impacts of the illness on the ability to work, as well as impacts to healthcare systems as a whole. This will only continue to rise as ongoing COVID infections and reinfections drive up cases of long COVID. But 7 years into the COVID-19 pandemic, many hospitals are still recommending largely ineffective droplet measures, such as washing hands, wiping down surfaces, and drawing curtains, even though studies have shown that N95 masks and improving ventilation with MERV 13 filters, HEPA filters, can significantly reduce spread of airborne viruses such as COVID-19. So, Dr. Al-Aly, why do you think governments and health authorities worldwide are willfully ignoring these facts and no longer taking measures to stop the tide of COVID infections and long COVID?
I think there's quite a bit of pandemic fatigue, and I think sort of like that people are really want to move on from COVID-19 and just sort of pretend as if it didn't happen, and that I think is driving a lot of that decision making. That sort of like, again, we're sort of ignoring the key lessons that this pandemic has already offered us, has already taught us. It taught us that SARS-CoV-2 is airborne, and actually you could reduce it dramatically with a better indoor air quality. And I would think that one of the things that we take from this is like, oh, okay, well, we know how to improve indoor air quality, and let's do that in schools, and let's do that in public spaces, and let's improve that. And actually, we'll not only reduce the risk of SARS-CoV-2, we'll reduce the risk of other airborne viruses. And also pollution, actually indoor pollution, which people don't really realize, actually, is affects cognitive performance, affects a lot of different aspects of daily living. You'll feel better, if you live in an environment where like the air is purified and cleaner, you have less inflammation, you have better cognitive performance, you have there's definitely better health outcomes. So there's a lot of dividends, a lot of sort of a return on investment for something that is simple that could and should be done. And I think the aversion to it is really primarily is pandemic fatigue. And then the second thing is really the heavy politicization of the COVID pandemic, and COVID and everything COVID. So this has been, so instead of being really a public health issue that is really concerns the health of Canadians and Americans and health of people, health of Europeans and people around the world, it became a political hot potato or political issue. And that politicization also, it introduces a lot of wrinkles in this story, sort of, and so the result of that is that people, instead of like learning from this and then putting systems in place to actually improve air quality and reduce the burden of infection, they're just like glossed over it and moved and are behaving now as if the pandemic never really happened and we did not really learn anything from it. And that's really regrettable because pandemics are going to happen again, and we're gonna face another big pandemic in 2030 or 2035 or 2040. And we're gonna find ourselves like, oh, we wish we had a better indoor air quality systems. We wish we did this in schools and public spaces and all of that, because now that we have been actually more prepared and build resiliency into these systems to actually face the headwinds of future pandemic with airborne viruses.
I totally agree. But one of the reasons we're doing an interview like this with you is there's still time. There's still time to do something, right?
Oh, there's always time to do something.
Yeah,
And this is why we're
exactly.
gonna keep pushing for this. Absolutely.
At the Living with Long COVID exhibit, which opened in Vancouver Museum in October 2025, one of the recurring stories told by long COVID survivors was that their doctors and family members often did not believe how sick they really were. They've been hurriedly told it's all in their heads. What key messages would you like to convey to physicians, healthcare professionals, and the general public who don't seem to be aware of the impact of long COVID?
I think knowledge is power, and I think that generally speaking, when I talk to people, I think that they generally we psychologize illnesses that we don't completely understand. And that over the past several centuries, this happened before. This happened many times. It happened with seizures. When people were seizing in the Middle Ages, because we did not understand that seizure is an electrical problem in the brain. We did not understand it to be organic disorder of the brain. We call these people possessed by demons. And like that these people are somehow crazy, and this is why they're seizing. Happened with multiple sclerosis. People with multiple sclerosis were actually, called like, you're crazy. I mean, these people were crazy because, we were scanning their brains and we were not finding anything at that time until the MRI was developed. And then they applied this new MRI at that time, new MRI technology to these brains. Like, oh, these patients have lesions. And then people started believing them. So we generally psychologize illnesses that we don't completely understand. An antidote to that is understanding it, is understanding what long COVID is and understanding the manifestations of long COVID is really, and that could improve things dramatically. So I think one of the key things that we need to continue to do and do very, very well is to try to improve the understanding of primary care physicians, healthcare providers, family physicians, specialists, medical students, trainees and residency and fellowship throughout the spectrum and society at large, what long COVID is, the different manifestations of long COVID. That knowledge itself will dramatically reduce that sort of the psychologizing of illnesses or the dismissal of illnesses by some. So I generally attribute that to lack of knowledge, that people are busy and they don't really they haven't seen it before, they don't understand it, and so they psychologize it, and that's sort of and this is not a novel response. This is a human response that humans have been doing for the past several hundred years with diseases that we don't fully understand.
Thanks for that fantastic answer. I totally agree. In the same line, the Chief Science Advisor of Canada, Dr. Mona Nemer, has called COVID a mass disabling event, but governments at all levels and health authorities continue to minimize the significance of long COVID. From your experience testifying to the U.S. Senate long COVID congressional hearings, what measures can be taken to urge our governments and health authorities to act now to increase funding for long COVID treatment and research?
I think people need to understand, the government need to understand whether the government in the US, NIH, and HHS, and the government in Canada and elsewhere, that we have now a generation of people who have been impacted by long COVID, more than 400 million people around the world, including many Americans and many Canadians. And these people need help, and that's a disease that I wish it would go away, but it's not going away. Like now we're several years after the beginning of the pandemic, and then there are still people with long COVID and still people suffering from long COVID, and these people need help. And like with any other disease, attention need to be devoted to it. And I'm really delighted to see that the German government has devoted some resources to address long COVID, and it is my hope that the U.S. government, that the Canadian government, that other governments in Europe, including the UK and France and other countries in Europe, would also do the same, because this is not going to be solved only by the German government. German government committed now to a decade-long, a 10-year-long, vibrant or strong research program to support long COVID or to research long COVID, including mechanisms and trials, like really a very well diversified portfolio of studies to research long COVID. That's really a meritorious approach. And it really is certainly a step in the right direction from the German government. We need more governments like that to do the same, whether it's in the US and elsewhere in the world, to really support a broad research portfolio to address the crisis of long COVID.
Thank you very much. I totally agree. Dr. Ali, there's so much to discuss about long COVID that I would love to have you back to discuss where you think long COVID will be in 5, 10, and 15 years in a future interview, if possible.
Absolutely, would be delighted to do it.
Thank you very much. Dr. Ali, we'd like to end our discussions with a ray of hope. Could you give our listeners a ray of hope for long COVID, and what gives you the ray of hope to continue your work on long COVID?
So when I reflect back on what we've done over the past several years as a humanity, as a community of scientists and patients and patient advocates and working together, I think we've done really in a very short period of time. We took a disease from obscurity, from a disease that didn't even have a name, to a disease that now a lot of people understand, a lot of people know, and we now know a whole lot more than we knew at that time about the mechanism of disease, the epidemiology of disease, the manifestations of it, the economic cost of it, the epidemiologic burden of it. And then when you go to PubMed, this a search engine, if you will, the Google of medical literature. So for those of you who are non-medical people who are listening to this, it's kind of like the Google for medical literature, and try to Google or try to PubMed the number of reports and papers that have been done on long COVID in the past several years, since the beginning of the pandemic. That's an enormous number. It's more than 40,000 papers, more than 40,000 scientific publications by people from across the world, from nearly every country on earth, all came together to try to find out what this new thing is. What are these people talking about? What are these people suffering from? What's the mechanism of this? How do we treat this? How do we understand this? The epidemiology of this, et cetera, et cetera, et cetera. And that gives me hope. That sort of massive response to a problem that literally did not exist in 2019. We did not have long COVID in 2019, you guys. We did not have long COVID in 2019. And then all of a sudden in 2020, we were faced with this new thing that we needed to understand. And we marshaled resources. We came together as humanity, community of scientists and researchers and physicians and patient advocates and patient scientists and the community, the broader community of people came together and done all that progress in a short amount of years. So that's really an enormous feat, so looking at things half full is always important. Now I do realize that we don't have a treatment yet, but we have a lot of leads. We have a lot of trials, and we have a lot of leads and a lot of understanding about the mechanism. That gives me hope that we will achieve significant breakthrough, hopefully in the next few years.
Thank you very much, Dr. Ali. That was a fantastic ray of hope. Many thanks again for taking the time to have this discussion about long COVID with the Canadian COVID Society and Protect Our Province, BC. Thank you very much.
Absolutely. Delighted to be with you.
And thanks to our listeners for taking the time to listen as we shine a spotlight on this condition of Long COVID Awareness Month. In these challenging times, I would like to close this discussion by urging our viewers to continue the fight for long COVID awareness with a quote by Mahatma Gandhi. You must be the change you wish to see in the world. Thank you very much, everyone.